I'm Dr. Shawn Tassone. Welcome to Confessions of a Male Gynecologist, a podcast dedicated to women's health and hormones, and pretty much everything else you were never listened to when you went to the doctor's office. I'm board certified in OBGYN and integrative medicine, and I have a PhD in mind-body medicine. I guess you could say I'm a little bit outside of the box. In this podcast, I'm going to get you the answers you probably asked 5 other doctors and were kind of blown off. I want you to know that I'm not only here to talk, I'm here to listen as well. And now, let's get to those confessions. Hey everybody, welcome back to another episode of Confessions of a Male Gynecologist. I'm your host, Shawn Tassone, and I'm thrilled to have another doctor on here, MD. I don't usually have a lot of MDs, oddly enough. Maybe they hate me, but Amy Killen is a board certified physician. I believe your training was in ER medicine. You actually were here in Austin for a while, and now she's in Salt Lake City. But I happened on to Amy because obviously my algorithm is a lot of hormones and women's health, and she really dives into this space. And one of the reasons that I follow you and that I really admire your take on a lot of things is because you're kind of one of those people that I think, like me, has a foot in the alternative kind of space. You're a little outside the box, but as an MD, we also kind of have to toe the line on our licensing and our training, and which I think is good, but I think we get a bad rap sometimes as MDs. But I like you because you're pretty honest, you're blunt, you call people out, but you also help a lot of people. So thank you so much for coming on. And I want you to kind of just give us kind of your history on how you got to this place in your life, in your career. You know, I think we all have a story as to how we got here, and I want to hear yours, and I want to thank you for coming on.
Well, thank you for having me. I'm excited. I think you and I tend to agree on a lot of things in the hormone space. And so it's always fun to talk to people who have, similar beliefs and mindsets. I was an ER doctor. I'm board certified in emergency medicine. I practiced in Austin, and I was in the ER for about 10 years. And kind of towards the end of that, I had my 3 kids within 2 years. So I had twins and one more, and I was still working full time in the ER, 4 a.m. shift every day, getting up at 3. And my husband had moved out of state for a job. So it was me and the kids. And as you might imagine, I was kind of starting to unravel a little bit, like not sleeping well, not eating well, just high stress, all those things. And, I think my kind of pivotal moment came one day when I was in the ER looking out at the waiting room. And I realized that if I didn't get my act together and make some big changes, I was going to be a patient in the ER, in 5 years or so with some sort of chronic medical problem that potentially could have been prevented if I had taken better care of myself and had better education. So I decided then to learn more about how to be healthy. And I eventually quit the ER in 2013 and I ended up landing in preventative medicine, hormones, a big focus on women's health, though I do see men as well, and regenerative medicine, a lot of fun things, but very different than the ER.
It's funny. My son is an anesthesia resident, and he just finished up a month in the ER, and he texts me all these things. And more than anybody, ERs a lot of the time tend to be like clinics for people that don't have insurance. And he texted me and said, well, this is great. I'm on the 8th hour of my ER shift, and I'm treating somebody with bed bugs. It's like, he's like, I thought I was going to be doing heart attacks and traumas, and it's like bed bugs. And
Yeah.
that has to be a little frustrating because I think, when we're younger and you're making that life decision of what do you want to go into, I kind of find, each profession has its own like personality, right? The ER guys were always those people to me that were kind of the risk takers. They liked the thrill. But in your career, what did you find were like the patients? I mean, you have that one person that comes in, you save a life, it's amazing. But what's the majority of patients that you would see in the ER when you were doing that?
Yeah, I mean, I loved the sick patients, and I say, the patients who I could help, who had heart attacks and strokes and traumas and things like that, who really needed to be there and needed my help. But the things that are frustrating are the people who just use the ER as their primary care because they can't get into primary care. failure.
Yeah.
This is a system failure, obviously. But you could have everything from chronic back pain to a lot of depression and anxiety and suicidal ideation, sunburns. I get people come to the ER for all kinds of things, and we're happy that we can provide that service. But I do wish the system was a little bit better in terms of being able to just offer primary care and psychiatric care in a better way than the ER.
But you also see the acute result of a chronic process. Like, when you mention heart disease, stroke, this doesn't happen in a week, right? This is 20 years of people either not knowing, neglecting, ignoring signs. And as a physician, I'm sure, you have a job because of that. But at the same time, you get these comments all the time online that doctors are just shills for pharmaceutical companies and we make all this money prescribing, which is totally against the law. But, you obviously got frustrated with where you were physically, and probably to a certain degree that you were making an impact in the occasional person you saved, but you'd probably see these people coming back, same people, pain meds, nobody's helping them. Um, I will tell you one of my unique experiences was I had an ER call me once when I was probably 15 years ago, and they had a lady with acute pelvic pain, and they did all this workup. They found absolutely nothing wrong, and they're like, "We need you to see her." And I'm like, "It's usually the other way around. I send people to you, not to you're sending." And this lady was just in a terrible amount of pain, and this was right when I had gotten out of the integrated medicine program at the University of Arizona, where you were also for a while, I think, or in Arizona. And I just asked her a question. It was so weird. It's just popped into my head. I said, because she was having this acute pelvic thing, and I said, "Have you ever been abused?" And she stopped crying immediately. And she said, "Well, not abused per se, but my husband and I just left me for a younger woman." And she said, and I said, "Oh," and then she went, "But when that happened, it triggered this memory that I had blocked where I was raped when I was 16 or 17 and they tried to drown me." And then I was sitting there like, what do I do now that I've ripped this scab off? And I felt horribly inadequate to help her, but it wasn't an emergency, right? It was this lingering effect from this, psychological trauma she'd undergone. Um, so it's a very nuanced field that we're in, and I wish that people understood that. Yes, it's a job. We make money. None of us are starving to death, obviously, but there's a lot of us out there that are trying to spread this message of prevention. Like you said, you started going into prevention. What are some of the things that you see in your practice? That are, especially in women's health, where women are basically getting neglected by the system.
There's so many things. And I think back to my ER days, and I was complicit in that. Women would come in, for instance, with like classic low thyroid symptoms. Like, they can't get out of bed, they're constipated, they're losing hair, they have extreme fatigue, and feeling miserable. And they would come in, of course, I would run thyroid tests, but the way that I looked at those tests was so different than the way I look at them now. And even if their TSH was 6, I would send them home and say, "You need to see a primary care doctor and maybe get on some thyroid medication." But like, I wasn't the one doing that. And there's just so many things. Certainly, a lot of hormonal, perimenopause and menopause. Obviously, I focus a lot on that now. I didn't even know what those things were when I was in the ER. I mean, I think I had heard the word menopause, but I didn't. I did not do any sort of evaluation for this. I had no education at all in that area. Like, once a woman turned like out of childbearing years, I really didn't know much about how to treat her differently than men in the ER. And I think that, obviously I've learned a lot in the last decade, but I think a lot of doctors are still in that space where they just really haven't had the education.
So my listeners know my background and how I did what I did and why. Um, when you get to that point, you're in the ER, you're thinking, I don't want to do this anymore. It's slowly killing me. Um, what was your first thing? Because where do you okay? Because this is like a major life decision, right? You
Yeah.
could you could fail, you could go broke, but you can't keep doing what you're doing. What was it that you did? Like, where did you go? How did you expand your training? Because it's not like you just hang a shingle and say, well, some people do that. Obviously, they're
Right.
online all the time. But most of us that have this training, I was this way. I was like, I don't want to just go to some laissez-faire place and get some certificate that's made up. I want to
Yeah.
get an actual training. So that's why I went to the integrated medicine at U of A. But what did you do? How did you even start your journey?
I kind of cobbled together a lot of different trainings. 'Cause I didn't at the time. I'd never heard of this field of medicine. I had no idea what this was, and yeah, it was kind of just a leap of faith. Like there's got to be something else. So I started out doing some courses through AMMG, the
Hmm?
Age Management Medicine Group, and then I went through a an unofficial fellowship program through A4M, which was
Hmm?
the metabolic medicine.
It's not unofficial. I mean, they've been around now for a
I mean,
long, long
it's not
time.
an actual like recognized fellowship,
People
but it
don't
is a
understand
year-long
this is
program.
expensive too. I mean, it's you
Very
got to
expensive.
invest in this and you still don't know what you're doing, right?
Yeah,
You're
it
just
is.
gathering information. You don't even know if it's going to work. It's
It
scary.
is. It's a
Yeah.
it's a year long program, lots of courses, and then actually a written and oral boards at the end, which is kind of interesting. So I
But
did
that
that,
I
and at
think
the
that
same time,
lends that shows you know what you're talking about. I mean,
yeah,
that's a good program. Yeah.
it is good. It is good. But I also did some other hormone courses. That were kind of on the opposite side, like I did the World Link Medical courses with Neil Rousier, which is very different than A4M. I tried to kind of start learning from different perspectives so that I could really form my own opinions about some of this stuff as I was getting started.
Okay, set me straight because I have done a podcast on WorldLink and Rousier in particular. I find this is just my opinion because I've never done the training. And Lauren Fitz, who is an anesthesiologist, and I have gone after each other online because I feel like, and you can tell me, you can set me straight, and I'm more than happy to be humbled by you. Um, do you feel like some training programs teach doctors to overdose on hormones, like high level, like especially testosterone with WorldLink, that it's okay to have a level like 250 or 200 or 300?
Yeah, I do. I think that Dr. Rousier is very, very smart, and he does know the literature better than anyone I've ever met. Like he does know the literature. His interpretation is a little different than mine in some cases, and I do agree. Like I think that the testosterone is one area where I don't think that going that high is a good idea for a lot of women. I see too many side effects from
Yeah.
testosterone. I also, he's a big fan of only using oral estradiol, and
Oh
I think that
wow.
there
Okay.
are times for that, but I don't think that everyone needs oral estradiol. I think that there's some things like that
So
that are.
you don't go straight to oral estradiol. I use it too, but like yesterday I wrote a prescription, but it's like my last choice
Yeah,
usually.
I would say it's not my last choice, but I don't necessarily. It's not. Yeah, I think you have to opt into it versus opting out of it. Like you have to check all the boxes
Sure.
and not be high risk for various things to use it versus going to it straight away. But I do understand that the best evidence that we have for like cardiovascular disease prevention is actually with oral estradiol versus transdermal. So I can see why. I understand where he's coming from on that.
The point being, there's choices. And I think
Exactly.
in most cases, like the lady that I prescribed it for yesterday, she's training for a triathlon and she's swimming all the time. So the cream wasn't working because it was getting washed off. And then she hated the taste of a troche, the sublingual.
Hmm.
And, and then you have that discussion with her and you say, here, okay, well, I have oral. It does go through the liver, but it might increase your risk 1 in 1,000 or 1,500 for a DVT, but it's an option. And I think most women aren't even given that. I mean, do you find that this is my thing? I see women who have already seen like 5 people. And just like you said with the thyroid, and we're going to go a little deeper into thyroid. Oh, you're fine. You're normal. You're just getting older. Um, you just got to tough it out. The extra 10 pounds, that just happens to everybody. I mean, are you finding that women that see you are probably, you're not like usually their first doctor?
Right. Yeah. The same. Yeah. Exact same. And I think that we all have a different way of doing things. But what I think is so important is to be able to pull from a lot of sort of a bag of tricks that has a lot of tricks in it. To be able to use pharmaceutical products, but also compounded products. To be able to use various types of hormones, and like you said, like whether it's sublingual, creams, sprays, gels, patches, like to have all these different options because it is true. Unfortunately, women all react differently to hormones and
Mhm.
one form or dose may work in someone and not in her twin sister, and so we have to have the ability to really pivot and choose different things and not just be on a course of I'm only going to do it this one way.
And, I've also done a few episodes on the North American Menopause Society, now called the Menopause Society. Um, I don't, I'm a GYN and I don't understand the hatred of compounded hormones with these organizations. I remember 20 years ago, the first president of the North American Menopause Society, Wolf Utian, um, made a comment. I remember this. Any doctor that uses bioidentical hormones 20 years ago was a quack. It literally said quack. He then wrote a book on bioidentical hormones like 15 years later. But they still won't come around to one. They don't talk about testosterone at all. And two, they have this deep hatred for compounded hormones. And I mean, I've been using them for 20 years. I'm sure you use them. Do you find that our colleagues are limited still in what they believe because of these governing bodies?
Yeah, I think so for sure. I think that, the traditional kind of allopathic organizations like Menopause Society are in many ways just, a decade or so behind
Yep.
what the functional medicine, integrative medicine, some of these kind of quack unquote, organizations were doing 10, 20 years ago. Like, so, the idea that bioidentical hormones are safer and, probably better for you for a lot of women than some other forms, like we've known this, I've known it for 13 years, you've probably known it for 20 years, and we've been doing this for a long time. And I think the compounding is another thing. Like, I think any doctor who's been doing hormones long enough, most of them will start to use some compounded medications. But some of these doctors who, I'm happy to have them. I'm happy that they're doing hormones now and offering it to women. But I think they just haven't been doing this stuff long enough. And absolutely, NAMS, et cetera, needs to embrace the idea that compounding pharmacies are not dangerous. They do have oversight, and there can be a great option for a lot of reasons.
And the hormones they use, the estradiol, the testosterone, the progesterone, the DHEA, they're all FDA approved. The hormones are
Yeah,
FDA approved. The compounding isn't FDA approved because that's not what the FDA does. But,
right.
and it's funny because I can show patients their levels change. I mean, it's obvious that they're doing something, they feel better. It's just so frustrating because I always feel like there's just this target that they put on us, like we're fringe practitioners, but it's like, but they'll put a patch on. And what's funny is they also say this, and I want to get your opinion on lab testing, but they'll always say that they don't have to lab test because the hormones fluctuate and blah blah blah. But when they do the in order to get something FDA approved, like say the estradiol patch, they do lab testing. That's how they know what the doses are. So
Right.
they're talking out of both sides of their mouth. I mean, what is your view on lab testing?
I
Essential or
think
not essential?
I think it is important to do lab testing with the understanding that various hormones are going to show up various ways in the lab. Like, I think, like, I like to do estradiol testing because I think that women do absorb estradiol very differently depending on skin type and age and various things like that.
Definitely.
And so I do want to know what their range is, with the understanding that it is going to, it's going to vary depending on when they took their medicine and, when we draw the lab, et
Sure.
cetera. I think that, some hormones maybe aren't as important. Progesterone, for instance, if you're doing oral progesterone, by the time you test it in the
Yep.
morning,
Yep.
it's pretty much out of the blood. So, as long as you know the dose you're giving them has been studied and, offers uterine protection, that one maybe you don't have to check. So, but I do think that the blood testing, I still don't really understand why we're not doing it across the board. I think it is important.
And it's the party line. It's really the part. It's almost. I always kind of say, like, I think a lot of my colleagues don't want to test, and I always try to defend my colleagues and say, look, OBGYNs see 50 patients a day. The high ticket items are going to be pregnant women because it's a $3,000 reimbursement at the end, and a woman on hormones, it's like $60 for a return visit. Usually, those women take longer because they have a ton of questions, and to sit down with someone and go through their labs, it's going to take a while, and they can't keep their clinics open because they just simply can't get reimbursed for it.
Yeah.
And I just feel like some docs don't order labs because they don't want to know because they just don't have the time.
I think that's true. And I'm actually just wrote a Substack article that's coming out soon about this, but I went through like some of the major forms of hormones, and I went through and all their pharmacokinetic curves to see kind of
Yeah, I saw that. That was
when they
great,
reach steady
actually.
state.
I think I
And
reposted one of them. Yeah.
thank you. Yeah. And so I have a whole article coming out, but I did that because I wanted to see for myself, like, what do these look like? And it is very detailed and difficult to, you don't have to know exactly what these curves look like, but in order to really understand what a lab test means, you have to know, like, well, would you take the dose of each of your hormones, and how long has it been since then, and what do we know about how, the half-life, and how long it takes to peak, and like, there's a lot of stuff you have to know. And absolutely, it is more time investment than most doctors. If you're in the insurance model, then it's more time than you have to devote to a patient, unfortunately.
Yeah, and not to mention the time and money that we've invested over the years learning this stuff. Or even what people don't understand is, I went cash based 2 years ago and I was a wreck. I was like, I don't know if anybody's going to want to see me. I have that imposter syndrome where I'm like, why would anyone come to me? But I have half an hour I can spend with somebody instead of 5 minutes. And it's so much nicer for me now. I'm like happier because I'm not like killing myself slowly. I can keep my office. I've been giving my employees raises, and it's hard. But I totally agree with you on the progesterone. I order it because it's just part of the panel that I
Yeah,
order. But I have patients all the time. Oh, my progesterone's 0.2, and this naturopath or somebody said it should be 10. And I'm like, well, but yeah, you take it at night. And if
yeah,
it was 10 at 3 in the afternoon, you'd probably be falling asleep all day because
right.
and it is true. And you got to walk people through that and kind of explain it. And that's why I always ask, how are you sleeping? Oh, I sleep like $1,000,000. Okay, well then it's probably your progesterone's fine. Um, what is since we're on progesterone, we've got the same thing. You've got oral progesterone that's been around for probably 20 years and covered by insurance. You've got topical creams. You've got sublinguals. Do you prefer? Because this is online all the time. Do you prefer oral progesterone, or and then are you a big fan in menopause of cycling or consistent dosing?
I do like oral progesterone. I think it's my go-to for
Yeah,
progesterone.
yeah.
Certainly some people don't tolerate it, but I do start with oral usually. And I think, 80% or so at least do tolerate it well, and it's great.
Hmm.
I don't cycle in general. I don't think it's a bad thing, but
Yeah.
people just don't, I don't think most women want to have, bleeding in between and things like that. And I have looked into this a little bit. I'm trying to look at the data for cycling versus non, and there's not a ton of
Yeah.
data that really compares. But I'm open to it. If something comes out and tells us that cycling is better, I'm open to learning
You're
about it.
you're a lot nicer than I am. I don't even. I kind of look at it like you said. I haven't seen a ton of data that shows it gives benefit
Yeah,
in a 70-year-old woman, and then she's got to go buy pads or tampons. It's like
right.
I don't personally see the benefit, but
And then also
um,
you have 2 weeks where you're not sleeping as well, and 2 weeks where you're more anxious, and you're not getting those benefits for 1 or 2 weeks, depending on how you're cycling it. So to me, it just doesn't make good sense to put someone through that.
I have a friend who's a psychiatrist, and she told me the other day that she doesn't know of any data that shows that progesterone helps with anxiety. And I'm like, I could, I could call 100 women right now that are on progesterone, and so I don't. Do you know of a specific study that shows that? Or I mean, I
Hmm.
know we've both seen it thousands of times, but I
Yeah,
don't know of a specific study.
I don't know of a study off the top of my head, actually.
I mean, we know it upregulates a GABA receptor, which
Yeah,
ultimately can calm you down. But yeah, it's really because here's the thing: who's gonna fund the study? Because progesterone now is generic, so there isn't a lot of money to be made by pharmaceutical companies, and
yeah,
unfortunately, that's what drives pharmaceutical research is the potential to make money,
yeah.
as we've seen with GLP-1s. But let's segue into GLP-1s. Are you a big fan of those?
I am. Yeah, I think that they can be fantastic.
And what is your take on all of the fear that's still out there? Like I'm sure your algorithm's similar to mine. You go on there, and I'll see 3 or 4 posts a day on how Lilly's getting sued for $8 billion for the eye damage. But then I'll see some. I just saw some this morning that cardiovascular, the for the first time, I think literally ever, heart disease has gone down. Heart disease deaths have gone down, and they think it's because of GLP-1s. I really personally, my feeling is in 20 years, this is going to revolutionize medicine in many ways. And I think obesity might be gone, eventually.
I think, I mean, certainly every drug has potential risks. And we recognize that, Tylenol kills people every
Yep.
year. Like every drug has
More
risks.
than GLP-1s.
More than
Yeah.
GLP-1,
Yeah.
absolutely. So we have to recognize that. And there are always downsides, but absolutely, every day new studies come out about the benefits of GLP-1s, neurologic benefits, kidney benefits, mast cell dysfunction benefits. Like, the list is super long. And so I do think that it is changing the way we practice medicine. And I think people talk about like microdosing GLP-1s.
Mhm.
And of course, we don't really know exactly what that means, but I do think that we'll see more and more studies at different doses and different ways of dosing. Maybe it's not every week, maybe it's every 2 weeks. Maybe, there's different ways to do this. But I think that these drugs are revolutionary.
Tell me, because I've never talked about this in my podcast, and I don't think I've even mentioned it online. What is regenerative medicine?
Regenerative medicine is, I mean, loosely, it's just it's trying to signal your body to repair itself. But mostly we're talking about using like stem cell therapy, stem cells, PRP, exosomes, things like that, or other treatments. It could be using
So
low intensity
what's a
chakra
stem
therapy.
cell? What's a stem cell?
So
I
stem
mean,
cell, in your body, all of your tissues you have stem cells that are the cells that are responsible for the general upkeep of those tissues. So these cells can replicate and they can also differentiate into other types of cells. So you need them all over your body to repair and regenerate your tissues. And what happens is as we get older, the stem cells that we have, they become less active. They become less able to repair. They're not sending out the signals as they used to. So this is why, if you cut your arm when you're 8 years old, it repairs in like 2 days versus if you cut your arm when you're, my age, almost 50, then it takes like a
oh
week
my
or more.
God, you're almost 50?
I am.
I would have
It's been
I
a
thought
couple of
maybe you were
months.
honestly, I thought you were like 39. So
Oh,
there,
thank you.
yeah,
Thank
there
you.
you go.
Nope. So anyway, so stem cells get old essentially as we get old. And so the idea behind stem cell therapies are to use stem cells either from somewhere else in your body, like your bone marrow or your fat, or even using like placental tissues
Mm.
to stimulate your own tissue, your own stem cells to become more active.
So what's the difference then for my listeners between stem cells and PRP?
So PRP is platelet-rich plasma, and that just comes from drawing your blood and we centrifuge it and we get the platelets and we concentrate the platelets. And the platelets actually have some great growth factors in there, some signaling molecules, because they're the first on the scene when you have an injury. And so they're sending out messages to increase blood flow and increase, healing. So PRP is kind of like at a lower level of regenerative medicine. So it can work great, but often you need multiple treatments. Like if you have a knee that needs to be repaired, you would do maybe 3 treatments of PRP over 3 months. Stem cells are kind of like a step up from that. Essentially, they have more signaling molecules. They're also live cells if you can get them, and they're sending out not just the growth factors but also messenger RNA, which I know has a bad rap, but it's
Yeah.
actually very beneficial, and things like that, so that there's a stronger healing response potentially. These things don't work for everything or everybody, but they, about 80% of people who are good candidates will have improvement in symptoms in general.
Yeah, I don't want to lose half my followers, so we'll stay away from vaccines.
Exactly.
Doesn't matter what you say, you'll piss off half.
No, you will.
Um, so, okay, I'm 57. I know I only look 56, but I'm 57 and I come to you and I'm like, I feel okay. I've got the usual aches and pains and stuff, but I've really been looking into, I want to just feel better overall. Is that a case for considering stem cells, or do you have to wait till you have some issue?
No, you can absolutely do them early. A lot of our patients they don't have a lot of problems. They're kind of like these biohacker people who are just trying to do all the things. I will say, of course, the research for preventative, IV stem cells or preventative stem cells of any sort the research is minimal because that's just not being studied.
Sure.
But there are some early studies looking at like IV stem cells, for instance, for like frailty. There's been some look at frailty in older people and just using IV stem cells to improve, how far you can walk in 6 minutes, or how, energy levels or things like that. And they're promising, but they are early studies at this point.
Is this something you have to go back and do like every couple months, or what's the treatment protocol?
It depends on where you go. Usually most people will do it, again, it kind of depending on what you're treating. If you're doing like a specific body area, like I do a lot of injections for skin, like I'll do skin injections, scalp injections for hair growth. I'll do sexual injections. Those usually will do maybe once every few months for 2 or 3 times. If you're local, if you don't, I have patients who come in from out of the country, and of
Yeah.
course they don't come back more than once usually. But sometimes just once is enough. Like if you have knee pain, sometimes injecting it one time is enough, and your pain goes away, and you're good for 2 years.
Do you use peptides in your practice?
I do use some. I know you don't love peptides.
No, it's not that I don't love them. I love I actually use BP 157, and I'm an experimenter. I'll try anything. I just don't prescribe them because again, it's that concept that when you get these, and I'm new to it too, so that's a little bit of my own ignorance. But it's one of those things where when people buy them on these weird websites, you don't know what you're getting,
Yeah.
and then it says on the bottle, not for human consumption.
Yeah.
But maybe you can educate me. Are these things that are now, can you get these legitimately from like a compounding pharmacy and that they're legitimate? And then maybe you can tell me how does a physician get, like, I mean, you did this. How do you get into peptides? How do you learn about them?
Yeah, yeah. Well, I only prescribe peptide that I can get from a pharmacy, from an act, from a from a 501, 5013, whatever,
Yeah.
503B, 50, whatever, an actual compounding pharmacy. There are multiple across the country, although you have to kind of shop around a little bit because it's not all pharmacies have all the different things. And certainly there are some peptides that are on the FDA's do not compound list, and those are not ones that we can get really.
And is
Even
that
BPC.
because there's a drug company that's investigating it to make a medicine out of it?
Probably.
Yeah.
It probably
Does
is
it
because
work? Yeah.
they're ones that we've used forever. Like BPC 157 is on that list, and so that's one that we've been using forever. And yet now, they say it's potentially dangerous, so they don't want anyone to compound it. But so you have to go, you have to go through compounding pharmacies. I definitely don't recommend that people go get the research peptides from just random online places, because I do think we have no way of knowing what's in those peptides, even though most of them probably are actually pretty good. And as far as training, there are a bunch of different. I've gone through, kind of like with hormones when I first started out, I just did some different courses
Hmm.
online, and attended conferences and talked to people, and just started kind of doing my own research and putting together like a catalog of information, and have just been kind of building on that as I've gone. And new peptides come out all the time, so it's hard to
Hmm.
stay up on this. So I don't know everything by any means, but I'm just trying to at least know the basics.
Okay, you're making me feel so inadequate. I'm gonna have to go on.
No.
No, this is actually educational for me. What would be okay for we got a man, we got a woman. As a 57-year-old man, what three peptides would be something that could be beneficial for somebody that is in my age group that's looking maybe to just live a better life, maybe build a little bit of muscle mass, look younger, feel younger?
Well, I do like BPC 157. I think that is a fantastic peptide especially for repair and recovery. Gut is good for gut health. It's also good for musculoskeletal healing, or even like workout recovery. I also like some of the growth hormone secretagogues, so the things that help you increase your own growth hormone production,
I
like
like
sermorelin.
Samorelin. Yeah.
Yeah, sermorelin. I don't like that one as much as some, like testosterone can do a better job, but it's also more expensive, so you kind of have to weigh that. I like some of the topical peptides too. I like GHK copper, which it's in skincare products as currently, and
Yeah.
it's for
Right.
skin and hair. That's a great peptide, and you can also inject that one. It's probably one of my favorite ones to inject, but it's also one of the harder ones to get because of that FDA list. But GHK copper is important for full body health and restoration. You do it in cycles, but it's a great one.
Couple of years ago, I was going to Mexico and somebody told me about melanotan because I'm about as white as a person can be. I didn't use it very long, but I didn't. I mean, I have seen people use it and they get tan like within a week or
Yeah,
two.
very tan.
So there's really interesting stuff out there. Would you say it's the same for women, like the BP 157, tesamorelin, and some of the others,
Yeah,
or
those are some of my favorites. And especially with the GLP, all the GLP-1 use, I think that one thing that's really that we use a lot are the growth hormone secretagogue peptides like tesamorelin, because, you're trying to maintain muscle mass in people who are also trying to lose fat with these medications. And in fact, I know like some of the next generation GLP-1 drugs that I was just reading about, they've actually combined, along with the other three, GLP, GIP, like all of those, they've combined an IGF-1 activator in there
oh
to
wow.
try to increase muscle building with these drugs. So it's going through FDA approvals right now. But the idea that we should try to help maintain muscle mass, especially as we get older, and especially for women, I think that's a big issue.
So what's interesting is that a lot of the people that are out there talking smack about GLP-1s, the coaches and the trainers and all these people, they'll then do a video where they're injecting themselves with NAC or NAD, and they'll and they're type peptides in the comment below and you'll get my, but
Right.
lest we forget, semaglutide and tirzepatide are peptides. That's how they
Totally.
started. And Eli Lilly figured out, hey, this is a good thing. And that's what they do is they'll take these things that we can prescribe and then they jack the price up by 10 and they make a bazillion dollars. What's your thoughts on the new one that's coming out, Retatrutide? I mean, it's like getting a lot of publicity now.
Yeah, yeah. I mean, I have heard very good things about it. I've had. I mean, obviously, I'm not prescribing it because it's not even FDA approved yet. But I
Right.
do have patients and people that I know who have used it and say it's phenomenal and it's better than the other two by far.
Yeah, and it's like, semaglutide works on one receptor, tirzepatide is two, and retatrutide is supposed to work on four, like
Yeah,
glucagon and some other areas. And I'm excited about it, but like you, I'm eagerly waiting for us to be able to use it. Obviously, if it's picked up as a medication by somebody, it's going to be really expensive.
yeah,
But so, as far as when somebody comes to you, and you have an office here in Austin, don't you?
yeah. We have a Humanot office in Austin.
What's it called?
A Humanot, like
Human.
astronaut, but with humans.
Yeah.
Humanot Health.
NAUT.
Yes, exactly.
When I was doing my philosophy PhD, what I was doing was I traveled to South America and I stayed with indigenous shamans, and I would just watch how they healed people, like just to see. My mom had passed away, and I needed something else to do,
Wow.
and I spent way too much money on a degree that didn't really. It's not like I can brag. I have a PhD in philosophy,
I don't know.
but
It's pretty interesting.
I think I can think really hard. But I use the word psychonaut all the time, like astronaut, but with
Uh-huh.
psychedelics. Like I said, I'm willing to try anything, and I think part of the thing is, especially as practitioners, what I find is there's a group of us out there that are willing to do that. Like we're willing to be open to possibilities. And then, you kind of have to be that way. But in so doing, we also have to try to figure stuff out like that hasn't happened yet. And I mean, how do you manage, you're busy, obviously, you have businesses in other cities, and then also try to keep up on all this stuff.
It is really difficult. I mean, I try to spend, I try to spend at least 1 or 2 days a week just reading/writing. And usually it's like a weekend. Like usually I'll spend a whole Saturday or whole Sunday
So
reading
you
and
don't
writing.
have people write for you. You actually do it.
No, I do it myself. I do it. All the research and writing I do myself because I learn so much, and it's silly. Like I'll spend 6 or 8 hours on a stupid Substack article, but I feel like it's worth it because I come out of it with information and knowledge that I didn't have before. But it
Do you,
is a
do
little
you,
bit of
do
a
you have
waste.
like a sign on your door for your kids that say "Mom's writing, don't bother me"?
They know, like I'll go into my office and have like my little cave, and I'll just be like head down for a whole day, and they'll bring me food sometimes,
No,
like
that's nice.
slip it under
Yeah,
the door.
a little charcuterie under the door. Yeah, that'd be nice.
Exactly. But yeah, I mean, I don't think any of us can stay up on everything. I think we have to just do the best we can. And I'm in this longevity doctors group, and there's a WhatsApp group, and there's like I don't know hundreds of doctors in there now. I started out with like 5 of us, but now it's a bunch of people. But they're always posting like all these different new articles and new studies and new things they're
Can
learning.
you invite me to that?
Absolutely. Yeah, you would love
Yeah.
it. It is kind of overwhelming. Like I'll be away from it for a few days. I'll come back and there's just this list of things that people are talking about that I'm just like, oh my gosh, when am I going to have a chance to read all of these things?
Now, do you have a book coming out, or did you get a new book deal or something like
I
that?
do. I just got a book deal with Hachette, and we're gonna. It's not going to be till early
Yeah, it's
2027.
always 2 years. Yeah.
Yeah, so it'll be a little while, but I'm excited. Well, it's going to be an interesting time.
Yeah, the book deal thing is really cool. I mean, I when I did my book, I flew out to New York and had like five houses and they bid on it, and it's really pretty exciting. And then you're all excited, you get your book deal, and then it's like 2 years later.
Yeah.
And I remember I submitted my first draft, and I had this great relationship with the editor and everything, and she said, this is not the book we asked you to write. And I was like, what? She goes, they kind of hated it. And I was like, oh, I was just devastated. But here's the thing, it did eventually, it came out amazing. So it's a people don't get it. It's a rough process. And when
Yeah.
somebody goes on Amazon and leaves a 1-star review because the book showed up dirty, you're like, oh my
Oh,
God, that has nothing to do with me. But
like
it's
you put
just,
your heart and soul in that
you
for
you
years.
take it so personally, and it's just, I mean, it like it's like giving birth. I mean, well, not exactly, but
People
you
have said
spend,
that. I've heard that.
yeah, so it's coming out in 2027.
Early 2027. Yeah, it'll be
What's it
out.
on?
So it's kind of it's a women's longevity book through the lens of reproductive health as a driver of aging. So
Okay.
looking at ovarian aging and hormones for sure, looking at some regenerative options, looking at just women's health, but how like kind of through this lens of ovarian aging and aging of that system. Sexual health, a big piece of that as well.
Have you heard anything about stem cells and ovarian reserve? Like, is there a possibility at some point we can wake the ovaries back up?
Yeah, I mean, people are doing stem cells and PRP into the ovaries. I will say that the early studies look promising. They're all small. They're all case series. We don't have big studies yet, but they look promising. It's for people who still have ovarian follicles, that they're just, like people who go like POI patients, people who have some follicles, but they're not, quite as good as they could be, or they have mitochondrial dysfunction or things like that. Certainly once you're out, like once you're 10 years into menopause and you have no follicles,
Right.
then obviously it's too late. But it's really interesting. I think that there is a place for it, probably in for fertility research, and certainly like in like the perimenopausal state potentially. But we don't have a way yet to, as you know, we don't have a way yet to like completely bring back follicles that are gone.
Yeah, so POI, premature ovarian insufficiency, is usually women under the age of 40 that are menopausal for genetic reasons, chemo, all these. That would be so amazing for a woman that's gone through chemotherapy who had ovarian function destroyed to be able to do something that could get the ovaries back online. This
Yeah.
is a horrible anecdote, but a guy that I was friends with, because I was involved with this tubal implant called Esure a long time ago, and I was the head medical expert against Bayer in the lawsuit, the class action. But one of the other doctors was a guy named Eric Sills, and he was on the doctors and all this stuff, and he was doing a lot of this stem cell stuff. And then now he's a Dateline episode for murdering his wife. So that kind of went away. But that was like my pipeline for this information. So I'll have to keep an eye on you if you start talking about
There's
that.
also some really interesting early studies on looking at essentially doing a partial, like taking out part of the ovary in younger women.
Oh,
And I think it's mostly been done in animals, so I don't think it's in humans yet. But taking out, maybe a quarter of the ovary when someone is like, the age of like a 20-year-old human, freezing it, and then
oh.
reimplanting it when they get close to menopause to be able to, lengthen time to menopause by 10 years or whatever. And in animals so far, it's pretty reassuring and interesting. Obviously, big jump from animals to humans to
Yeah.
do that kind of
But,
thing.
well, that's where our studies start, and it's funny because I always talk about this online. You'll see people like Huberman or Peter Attia or Dave Asprey. Um, they'll talk about how studies say this and it's in a rat, or
Right.
there were 8 people.
Yeah.
And it's like, I know we have to start somewhere, but people like you and I, we're not going to make these grand generalizations like you just did. You didn't, until we have sufficient data. And that's how I think physicians can be a little bit different, because we can be kind of gatekeepers of the information in a good way. By I try to save people money by, you see these supplements out there that say they can say whatever they want, cures every single symptom you have, and they have a 30-day money back guarantee. Nobody's ever going to ask for their money back. They just try and it doesn't work. And that's how it works. And then you've got us out there saying, well, that's probably not going to work. Oh, well, you just want to make a prescription. And it's like, well, no, not really, but I want you to feel better. Um, so if people want to work with you, well, first of all, if they want to find you, what are your main platforms right now?
So Instagram is my main social media, Dr. Amy B. Killen, and then my website is dramykillen.com. And then on my website, I have links to different clinics. I've got a clinic here in Utah. I've got a clinic in Austin and a clinic in a new one in Florida that just opened. And so those are all there. And then I also have some other projects and companies and things that are on that website. So dramykillen.com is the way to get to me probably.
What does the B stand for?
B is for Benet. That is my middle
Oh,
name. But I just
interesting.
think it's so fun, like Amy B. Killen, like let's Amy B.
Be
Killen it.
killing it. Well, when I first saw that, I thought that's what it was. I was like, what is she killing? Because I'm not sure. But yeah, it was. It's a good. Was it? It couldn't have been from the John Bonet thing. Is that like a family
No,
name?
I was named before that, and it's spelled different too. But it is.
Okay.
People always did ask me that.
So, in closing, what is a message that you want women to know? I know, I mean, you are a great example of you're almost 50, you look great, you look young. As a physician, what is something that you want women to know about health in general?
I think the biggest thing I've learned over the last years is that we, as people, as women, we have so much more control of our health than we think that we do, and that no doctor is going to make you healthy. Certainly, I recommend seeing doctors and having them go with you and be your kind of co-pilot and and help you navigate this. But it's your doctor is not going to make you healthy, and so like you have to really learn what health means to you and how to get there on your own, and then ask for help from physicians, in terms of getting medications and further guidance.
Thank you so much. This was probably the fastest podcast I've ever done. Sometimes I'm sitting here and I'm like, it's only been 18 minutes and I feel like I've been here for an hour. It's so easy to talk to you. I appreciate that so much. Well, I will stay in touch with you on Instagram. And
Yes.
actually, I want to talk to you when we get off here because I want to talk to you about maybe going into your clinic here in Austin and see what you guys do.
Oh yeah.
So thank you so much. Follow her on Instagram, Amy B. Killen, and in a couple of years, we'll be looking for your book.
Thank you.
Thanks for listening. If you enjoyed this episode and you'd like to help support the podcast, please share it with others, post about it on social media, or leave a rating and review. To catch all the latest from me, you can follow me on Instagram at Shawn Tassone MD, or on Twitter at TassoneDoc, and on Facebook at America's Holistic Gynecologist. If you're really interested in your hormones and you want to do a deep dive, get my book, The Hormone Balance Bible, on Amazon or other major retailers. Thanks, and I'll see you next time.